You are about to watch a webinar hosted by MGMA and AGMA regarding optimal telemedicine utilization. In this webinar, the various presenters will discuss how they started telemedicine, the marketing or how they got the word out regarding the new offering that they are hosting, patient flow and workflow issues, bandwidth, technology issues that they had, connectivity issues, and how they overcame those, what makes a successful telemedicine provider, the different platforms that they used, billing and reimbursement concerns, and lastly, the various patient types that they used on telemedicine for these patients. I will specifically mention the various platforms that they use because the audio is not the best in this webinar, unfortunately, despite my efforts. Okay, so they specifically mentioned Zoom, WebEx, VC, Victor Sierra Echo Echo, Doxy.me, spelled Delta Oscar X-ray Yankee, and then the period, Mike Echo, Doxy.me, Mend, Mike Echo November Delta, Google Duo, and Skype, as well as FaceTime. So hopefully you will find some value in this video, and let me know what you think.
Well, great. With that, why don't we just jump right in and flow right off of that last comment? I mean, obviously, you've had to both optimize your telehealth provision in your practices, and you hadn't had much time to prepare. It's gone from 0 to 100 for many medical practices. So let's talk a little bit about your organizational story for optimization. James, why don't you start and tell us a little bit about how you've ramped up quickly in the environment that we face right now?
Certainly. We actually had almost zero virtual health experience. As of the middle of the 20th of March, we really hadn't ever developed anything. We have two different platforms in our group, and one of the platforms actually had a built-in integrated virtual health platform, but it didn't translate to the other platform we had, to the other EHR we had. Some of our doctors were using that, but we really didn't have a large virtual health program at all. We had a lot of different reasons for that. There were the regulatory barriers. There were physicians not wanting to do it, fearful of patients not wanting to do it. I was always concerned about payment, what that was going to look like. Obviously, with COVID, when we suddenly went to shelter at home and you were having to figure out how you would be there for your patients, we needed a new world. We recognized that part of what made this work as quickly as we were able to make it work was the waiver that we were granted, the Cms Waiver that came about. That released a lot of the regulatory barriers that we had seen and that we were concerned about. Obviously, now you didn't have to be rural. Obviously, you didn't have to bring them to an office setting. The patients could take their calls from home. The doctors were allowed to see them. Additionally, they gave a parity in payment. And with that parity in payment, suddenly the doctors became more willing to do it. Previously, the difference in the payment kept doctors from wanting to do it because their overhead was the same whether they saw them in the office or saw them remotely. We recognized that where we would have had 6 months to have vetted, built a program, and had it integrated in our system, and to have trained it, done all the different parts, we really didn't have that. We had 2 weeks to put it together in a world where the rules were changing actively. We realized that you didn't need an integrated system as much as you needed an adjunctive AV platform. With the ability to use FaceTime, Skype, Google Duo, Zoom, Doxy.me, you suddenly had all sorts of options and people could explore them. And we were able to use that as a separate adjunct to the visit. We had to do some front-end work to help schedule the visits as virtual visits. We had to do some back-end work to make sure that we had the appropriate documentation in the visit. We had to train our doctors to be sure to comment on time. We had to put in some built-in statements that they could adopt to the visit that told them that they were seeing the patient for because of COVID, that they were doing it virtually, the patient had consented, and all of the different rules that were part of this. And we were able to get that together fairly quickly. We got a work group of billers, coders, technical people, workflow people to all sit in on this, and we were able to put this together rather quickly. With that group and with what we did, we were able to go from having virtually 0 telehealth visits to doing 800 a day within 2 weeks. And with that, we had one of the things that had been originally a big doctor dissatisfier was the fact that, I don't want to do this because it takes away from my office time. Suddenly they were realizing that they were going to be way down. And indeed, we've seen over the last month that without the virtual visits, we would be down anywhere from 70 to 75% on our office visits. With virtual visits, we're still down, but we're only down about 45 to 50%. So we've made up a lot of ground with our virtual visit platform.
That's great. Thanks, James. And Shane, I'd like to have you introduce yourself too, and then we'll dive into some of those very specific things that James highlighted. I just wanted to tell you, Shane, you may not be able to tell, but your camera went off, at least with me. If you want to click on that again, and so we can see you when you do your introduction.
Let me do that. There it goes. Okay. So yeah,
Great.
I lost audio and video for just a second, but now I'm back. So,
Okay. There you go.
There we
right.
go. So, yeah, just as James's group has experienced, we've experienced a lot of the same things. We are a large group practice, but we hold kind of a unique position in Western North Carolina, where we're located, in that we provide practice support to this entire half of the state. So not only are we coming up on telehealth ourselves, but we're also bringing about 40 to 50 practices with us. So it's always fun and exciting. We had used common platforms like WebEx and Zoom and things like that prior to COVID. And during COVID, we found that we had to move very quickly to come up on telehealth and to bring not only our psychiatry division, but also our family medicine and obstetrics division up on telehealth. So we originally took advantage of a lot of the changes that were going on. Many of our providers were able to utilize services such as FaceTime or Doximity to be able to come up quickly as we brought on a new telehealth platform, which we had been planning for about 6 months prior. And it just kind of expedited our timeline to be able to bring that service online. So with that transition, we brought our new telehealth platform up online in about 24 to 48 hours. And, as you can imagine with that, it takes a little bit of transition to kind of get all the back-end workflow done and get all of the providers on board and workflows with staff completed. And so, over the 2 weeks following that implementation, we spent a lot of time with a very large team to be able to work through not only the back-end billing components, which we're changing on a daily basis. North Carolina is one of the states that does not have telehealth parity yet. So that has caused tremendous amount of changes here in North Carolina alone, where we've seen payers come online with what parity would normally look like. So we've also implemented workflows for all of our MAs and our frontline staff to be able to help out the patient in adjusting to this new normal. Which in the rural area that we're in takes a lot of education to help bring those patients up online and deal with the barriers to access even internet services that they have. Outside of that, we've gone from, as I mentioned before, just doing psychiatry and different projects here and there with our school system to, now we're doing a little over 2,000 visits a week within our practice alone, not to mention the other practices that we're supporting in this endeavor. So, it's been an adventure for the last couple of years, to say that.
Absolutely. I appreciate that, Shane. And it's interesting as you talk about bringing kind of the bring everything up online. Maybe the two of you can, I'm not even sure marketing is the right word to use here, but you obviously have a demand of patients that need care in this crisis that are either COVID-19, potentially with the virus, or just everybody else for all the other care that is being pent. There's a pent up demand being created by all of this. So, how did you get the word out, or did you actually engage in an active marketing campaign with your practice to let people know that you were there, you were available for them? James, why don't you start with that?
We've done this on multiple different levels. It started even back into March 19th. We went around and our central privy offices coming out of Virginia sent an email to all the portal addresses and all the email addresses that we had, basically from the doctors telling them, here are the contact points, here's CDC, here's a connect that we want you to know. Here are the simple things: wash your hands, socially distance. And in doing so, we also at the bottom of it said, if you have any questions, call. And then as we all started going down into a lockdown mode, one of the first things we did was we used our data analytics tools and the information provided by some of our carriers to look at our higher risk patients. And we actually physically called them just to say, we're just checking on you. We want to make sure you know we're here. If you need anything, don't hesitate to call. We know you've got some higher risk, and we want you to know that we're here and we care. That went a long way to just giving people that personal touch. And the MAs suddenly found themselves with nothing to do in that first few days. So that was a nice gesture we were doing. Subsequently, we have seen groups in our area who've taken out full-page ads in the newspaper, basically saying, here's information about it. We want you to know that we're here for you. Call. We're doing virtual visits. Don't hesitate to let us know. We also, as we make appointments, or as we were calling patients to cancel appointments, we were calling patients and saying, can we transition this to a virtual appointment? The doctors were looking at their schedules and saying, let's see what we can do to make this one a virtual. Let's send them to the lab in advance so we can have a productive virtual visit. So, there was a lot of personal touch, a lot of one-on-one. There was some communication that was out there that we just wanted the patients done by email to let them know we were here. This started off as being much more about wanting the patients to be reassured. A crisis like this, we all recognize that the worried well were going to be a problem. We all recognize that anxiety about this, and subsequently you would have a lot of lonely issues. People who were trapped at home and feel very apart. To know that they can reach out if they needed us was an important part. And we used all sorts of different methodologies for that. I don't want to call them directly marketing, but we wanted them to know we were there.
Well, James, before I jump back over to Shane, I'm curious, because as you mentioned, Medicare had never covered telehealth outside rural areas before. So you have an elderly population potentially that may not be as used to using this type of system. So, I'm just curious, was that a different challenge, or was that the phone calls that you're referring to?
The harder challenge of that was, and I'll talk more about that in the workflow, but when we actually were doing virtual visits, is making sure that grandma and grandpa knew how to get on. I have to be very careful when I say grandma and grandpa because I've got 4 grandchildren. But a lot of the grandma and grandpas have already been doing FaceTime and already have been doing Skype and have already been doing this. So that the part of the CMS waiver that allowed us to use a familiar technology helped a ton with that crowd.
That's great. So Shane, why don't you tell us your story as well in terms of how you reached out to patients and how you let them know that you were there for them in this time of crisis?
Yeah, definitely. So us as well. It was more about getting the patients connected, continuing their care. Just as if they had been in the office. And for us, we initially saw that downturn, in late March, where our visits in our primary care and our OB side, did drop off by about 50 to 70%. And, I'm happy to report as of today, have returned to actually our normal levels of seeing patients through telehealth. So, a lot of that was accomplished through a multitude of different means, where, initially it was that one-on-one contact, going through our schedules, reaching out to individual patients, let them know that their visit was going to be transformed to a telehealth visit. Or the provider looking at their schedule the day before and being able to assess, what patients can come in versus what patients need to be virtual visits, trying to limit the number of patients that were coming in. So any of our wellness visits, any visits that were not respiratory related, really trying to convert those to video visits, if at all possible. When doing that, we developed a workflow to where not only are our front desk team and our schedulers calling to just finish the appointment over, make sure that the patient is familiar with the system that we're going to be using. We also have an MA that's calling that day to be able to do some pre-visit planning, make sure that the person can access the system, getting vital signs, going through the normal MA workflow to set the physician up for that visit and to make sure that it's a successful connection. From there, once we've kind of got that workflow nailed down, we've actually engaged in some television and some radio marketing just to help let folks know that we are still here, we're still seeing patients, we can do it in a safe manner, that they don't need to come into the office. We've also experienced in this area where some private practices have been closing altogether because of the event. So we've been helping to allow those patients to connect in with the provider during this time.
So why don't we talk a little bit, James, more about the Shane started discussing patient flow. Why don't we talk a little bit about that? We have hundreds of people on this webinar who are delivering care day to day, and so they and their staff have duties such as anything from scheduling to payment and to there's a new set of challenges, obviously, especially with if you have staff remotely working and such. And I'm just curious, from a workflow standpoint, how did you initiate that, and what seems to be working best in terms of getting people up and onto the system and ready to go when you need them?
What works best is exactly what Shane said. Believe it or not, that workflow is what we used to, and it's very effective. Our MAs get on board early in the morning. They contact the patient. Our front desk contacts them, says, "You're going to have your virtual visit today. We've done some looking, and your copay is going to be $15. Can we go ahead and collect that up front?" If we're going to collect copays, if that's part of it. We also tell them that they need to be sure that they've got all of their medicines. If they've got a blood pressure cuff, please check your blood pressure beforehand, weigh yourself beforehand. The nurse is going to call 15 or 20 minutes early and go through all of the usual nursing or MA functions, some of which are the usual promoting interoperability and ACO type of things. You can do a PHQ-9 over the phone. You can check their meds, ask them about their smoking, their balls, things like that. So you can get some of your quality metrics done then. And then they all make sure that the AV connection is working so that when the doctor gets on, the doctor is able to get on quickly and easily. The patient knows the call's coming, and they've been able to accomplish that. Our experience with this has been that it means the patient gets a few more touches over the course of the day, but it certainly expedites things when it comes down to the actual time frame that you're getting them in. The workflows are important. On the back end, the doctors have required training to remind them that they have to use the common phrases or the accelerators to make sure that they put the language in about why you did a virtual health visit, what platform you used, did you use Skype, did you use FaceTime, did you use Google Duo, what did you use? And they have to put in, on the back side with the billing, you have to make sure you have the right modifiers in so that you can get it out the door. So all of that is kind of in that of the day processing. Initially, this did indeed take a lot longer than having them come through the office. But we've gotten to where this is getting slicker every day. People are getting better at it, and they're becoming more comfortable with it. Patients are figuring it out quickly.
Shane, why don't you elaborate on workflow as well? I'd also be curious, Shane, one of the things I've heard from MGMA members and talking to them is they've had some success, but they're also reliant on the technology, and they're running into things like dropped calls and bandwidth issues just because of the volume. So I'd be curious if you've encountered any of that as well. But tell us a little bit about, why don't you add to your comments about scheduling to payment and all the other parts in between?
Yeah, so obviously for us, that was a huge thing of making sure that we were trying to mimic a lot of the workflow that we already have in place and be able to capture everything that we need to have a quality encounter. Starting off with the initial phone call, being able to add items into our triage menus. Is this the patient requesting an appointment that's suitable for telehealth, and then being able to direct them to a telehealth appointment with an appropriate provider. Making sure that they know what's coming as far as all the messaging, because our reminder systems have had to change, and the patient, just as James had mentioned, patient's getting a few more touches right now. So we're optimizing that at the moment, and then going through the MA workflow, making sure that all that information is captured. We're utilizing things such as text expanders and dot phrases and items like that to ensure that our providers are being able to capture everything in the encounter that they need, as well as we're throwing in some things from a research standpoint, so that way, hopefully, as this kind of continues on, we can have a nice published article that comes out of it to talk further about what's going on from a telehealth standpoint, and how this all transition. On the back end, from a billing standpoint, we've actually built several rules into our rules engine that captures our claims and stops them before they go out the door to ensure that the documentation is right, the coding is correct, it has the modifiers that are needed on the claim to ensure that before it goes to the payer, it's as correct as we can make it. Especially as things are changing on a daily basis, we're having to update the rules frequently to ensure that whatever the rule was at the time that the encounter was created is what's going out the door, to ensure that we can try to make sure that we get paid on it. As far as what you were talking about with drop calls and connection interruptions, and just I'm sure we've all experienced through different technologies we've used in meetings and various things. We have a backup in place. So, we have a primary platform that we use, and then we do have a secondary, we allow our providers to use secondary platforms such as FaceTime and things like that during this time, to where if for some reason our primary platform fails, they can go to that common platform that the patient's familiar with. And if all else fails, we can make a telephone call to the patient and continue the visit that way, and we capture that in the encounter, so that way we can watch those rates.
Great. So James, bring it down to the real sort of individual level, and maybe this is you, so you could talk about yourself or one of your colleagues, but can you talk a little bit about what makes a successful provider in this environment? It's a different skill set, I imagine, a bedside manner, so to speak, when you're on the phone as opposed to with the patient in person.
It's a lot easier in the patients who are established, who you already have a relationship with, because most of us have built a relationship over years with these patients. So they're used to seeing your face. You're not trying to introduce yourself. You're not other than yourself. I think that makes a big difference. We do have a situation where you've got some doctors who have always been rather aloof, and just by their personality, they are a little harder to read. Obviously, I wear every emotion that I've got on my face and on my sleeve, so I don't think that patients have a hard time interacting with me in this way. But I do know some of my colleagues who are more reserved and are more staid, and I can imagine that is going to be an issue that they're going to have to get through, because most of us recognize who've been in this business for any length of time, there's a certain degree of theater that goes on associated with seeing a patient, whether it's virtually or in real life. And in that theater, there is an interaction. And having that interaction is absolutely critical. we can tell more from just looking at the patient, seeing how they're responding to what we're talking about. You can tell when you're looking at them whether or not they understand the comments that you're making, the descriptions. You can know whether you need to stop and go back and explain it a different way, use a different metaphor. And those are the real critical parts. Some people do that very well, some don't. And I think that there is going to be a need for people to be a little more visible and a little more demonstrative, because they're not going to be able to have their entire body language. All they've really got is their face, their smile, how they communicate. And I think that is going to be, as this persists, it's going to be part of the skill set. I can certainly see that this would be more challenging with new patients. I can certainly see that this is more challenging with patients who are already apprehensive about what they're talking about. And if they can't read how relaxed you are or how tense you are, it can make a big difference.
Do you see this as an opportunity? I mean, it's only been a few weeks, so we don't necessarily have the processes in place to coach and get feedback and things like that. But maybe it's less formal now. But do you see that an opportunity for improvement along the way?
I absolutely do. I do believe that this is going to be something that's going to be part of your long-term strategy, whoever you are. That people have used the analogy of the genie out of the bottle. I also think that this is the toothpaste out of the tube. It's not going back. And at this point, you're going to have to figure out ways to see who does this well. And I think this will be part of follow-up after a visit, patient satisfaction that's going to be really specific to virtual visits. And you're going to use this to identify which doctors don't do as well. And in that program, you're going to say, well, why don't they do well? Can you help us to make them better? Can we train them? And I think that that's going to be a big part of the future of this. But again, as you said, this is now 4 weeks old for a lot of groups out there. And the ones who were using it before were using it as a part-time process, not their mainstay. This is going to be a more significant part of your service offering, I believe. And I think that being able to do it effectively is going to be critical.
Great. Shane, how about you? What's an example of a successful provider in the telehealth environment?
So obviously, in our situation, a successful provider is one that just, that kind of keeps to it as far as really embracing the technology and trying to make it work. Just as with anything new, there's going to be hiccups. There's going to be things that detract from moving to, something that's new. Our providers that have really stuck with it and tried to help the patient or have engaged assistance from within the organization or even with a telehealth vendor have been much more successful at engaging in telehealth visits. And we've seen those ones, like I said, go back up to normal volumes very quickly.
I had one question come in. I'm gonna ask you one more question that we prepared, but I do, just for context, I have gotten the question about what platforms you're using. You've alluded to some of the more sort of informal platforms, but are you on a specific telehealth platform, or just so folks have context to your comments? Shane?
Yep. So we're currently utilizing Mend as our platform.
Okay. James, how about you?
We're using everything.
Okay.
We've got some doctors using Zoom. We've got some doctors using DoxyMe. We have some who use Skype, some who use FaceTime, some who use Google Duo. We've got folks who are using VC. We've got any number of different things. One of our real projects coming out of this is going to be to identify a preferred HIPAA-compliant platform so that when the public health emergency and the waiver go away, we will be in a position to transition to a singular platform that we can use. But right now, we are letting everybody do everything.
Shane, you had a comment?
I did, and that's where I think a lot of providers are at right now. As a lot of folks have utilized the opportunity that's under the waiver, and as we go further into this, and hopefully most of the folks that are out there are already thinking this way. of what's next. Obviously telehealth is here to stay. We're expecting some changes that are going to really stick with some of the telehealth policy that's changed recently. And so providers really need to take this opportunity to now as things kind of in certain parts of the country start to calm down with COVID a little bit, where people can breathe and reassess. Is now that we've started in this situation, how do we move to the next step? How do we move to a HIPAA compliant platform that is going to really serve our long-term needs?
So I have one more question, and then we're getting a lot of really good questions from the audience. I'm going to go to that because I think that you're going to do a much better job at really articulating the challenges that they're facing day to day. But the last question is, how do you kind of wrap it up from a billing and reimbursement standpoint? We have reports of medical practices that revenue's down 50% or more. And so it still remains an important element of keeping your doors open in terms of this environment. So, well, James, why don't you tell us a little bit about that? Are there specific things you're having to do, or are your systems able to process this relatively, easily in the new environment?
One of the best things we got was when we got price parity that CMS came out with basically saying that whether you were in place of service 11 or 2, you do it from your originating. You're going to get a parity, so you were suddenly being able to be paid adequately for the work that you were doing, even for the Medicare. We then took a very aggressive tack in reaching out to all of our commercial payers and to Medicaid in our state, trying to get some clarity from them. Interestingly, prior to the COVID emergency, every commercial payer had a different payment policy. And when you called them, they would send you to your website. And just because they were on Aetna, it might be a different version of Aetna that had a different payment policy. And it was incredibly convoluted and very difficult. We reached out to all of them and basically asked the question, are y'all going to go along with CMS? Or are you going to be the bad guys and be the ones who are obstructionists to your patient care? And we took a very proactive stance of going out to all of the major commercial payers. Between the 4 major commercial payers, Medicare and Medicaid, that's 85% of our business. So we really wanted to push for parity. We also wanted to push for those that were waiving copays. And you had to be very careful with the definition of waiving copays. Basically, they were allowing you to waive it, but they weren't planning to pay it. They were allowing you to waive it, but you were still going to lose that amount of money. So we really pushed them hard to say, if you're going to waive it, are you going to pay it? And if you aren't, then we need to know so we can collect it up front for co-insurance deductibles. Mm-hmm. And we have been very active about reaching out to them. And we've created a grid that we have to update regularly because, as Shane said, these rules change almost daily. I would tell you that if you're in a small practice and you get told, you've got to go and reach out to the payer, they direct you to the website, which I guarantee you is at least a week behind, if not a month. And you're not going to know. You just absolutely have to talk to your payer rep, get it in writing, get them to understand why you're doing it so that they're ready with everything going forward. Yeah, I think you absolutely have to be that active about it, creating the grid, being prepared. The question of appeals and denials is going to come up. And right now, we're just starting to get our first payments in for these. Who's going to be the first insurance company who does across-the-board denials? And what are the reasons for those going to be? What are are you going to say? I think that that's going to be bad press. And I think that a lot of insurance companies are going to be reluctant to do that initially. In the long term, however, I believe that they will all start being much more aggressive. They're going to expect your documentation to say, why was this a virtual visit? Not just COVID anymore. You're going to have a reason why. And you're going to have the documentation of your time, of your medical decision making, what you have done. And you're going to have to be pretty specific about that. I think that you're going to have to learn how to work denials, work appeals, make sure your documentation is there. And so I believe that this is going to be one of the longer term problems we have with it.
Shane, what about your practice? How are you handling these challenges of billing and reimbursement?
Yeah, so just as James had said, really it is kind of staying on top of that grid per se. Yeah, we work very closely with all of our payers, including our state leaders, Medicaid, as we serve a very large Medicaid population in our practice. With that, it's a lot of it is putting the rules in place to make sure that claims are stopped before they go out the door. So that way claims aren't going out the door with errors on them. And those rules can include, things that, ensuring, anything that has a telehealth code or a telehealth certain phrases or things like that that would identify that claim as a telehealth being stopped to kind of undergo further scrubbing. On the back end, we have folks that are working through, and at least right now, we're kind of giving those claims an extra scrub just to make sure that everything's in place the way it needs to be. So 100% of our telehealth claims that are going out the door, are being visually seen by a human and not just being run through the system. And hopefully the next couple of weeks is we get payments in and we kind of see what's denying and what's being cleared. We'll be able to adjust our scrubbing and our rules to allow some of those claims to flow a little quicker and have less human involvement. Outside of that, it really is just kind of a waiting. It's waiting to see what's going to be paid, what's going to be denied. What nuances does the payer want? And, again, as James said, every payer is a little bit different. You have some payers that are requiring one CPT code for a telephone visit. You have other payers that are requiring different. So it's just kind of watching day by day what those rules changes are.
So I'm going to jump right into questions from the audience now. We've got a bunch of them. They're really good. So how are you handling, and again, this affects everybody differently because of specialty and geography, but we have these challenges of patients who live in rural areas or who may not have the video technology. We also have, payment implications because telephone only visits are paid at a significantly lower rate and don't enjoy the same parity, at least on the Medicare side of the equation, as audio plus video. So, Shane, my understanding is that you're piloting a program that might help address some of these issues of having both audio and video.
Correct. So, we are, piloting a process right now to where our patients that are in more significant need, these are higher risk patients that are having connection issues, where they don't have a device or they can't figure out how to connect in. We are going to be sending an MA with a driver to their home to do a home visit, get them set up on the platform, and make sure that they are able to access it appropriately. Or if they don't have a device, it's a situation where we may be bringing them a device so they can have their connected back in. So we're looking at anything under the sun right now. From having mobile hotspots that's like a vehicle that sits up at a school parking lot, that folks can come and gather around for their visits or things like that. It's a lot of thinking outside the box right now, how we can help with patients that just don't have the means to connect, how we can participate in their visits.
James, do you want to comment on that?
I would simply echo exactly what he said. I think that really here in Texas, we've got some rural areas just to the west of Fort Worth where there is poor connectivity, and that becomes a real challenge. We've had patients who said, that we've tried to take information out there, but if you don't have a signal, period, you're down to doing a phone call. I think that if you try to keep in mind that a portion of this is also about keeping the patient engaged, keeping the patient aware that you're there. Yeah, it may pay less, but it still may be a better touch to let them know that, you're still there for them. One of the questions that had come up here a moment ago, and I actually am reading the questions too, and they were asking about phone calls paying the same as video calls. I've seen different things about this. there have been interpretations that say that a 99213 done with a 95 modifier, saying that it was an audio visual, if it was phone only, they're still going to pay for it. And I've seen that, and I'm a little reticent to do that in and of itself. However, if that's the case, at least during this acute phase, then we should be using it to our advantage. I'm a little reluctant to do it, though, because that's really kind of different than what we've all been trained to do and what the books say. And Shane, if you have a different view of that, let me know. I can just tell you that I'm anxious about it, although I've read the same thing everyone else has.
Yeah, and I think for us, we're kind of the same. We're cautiously optimistic. We've seen some of our payers here within North Carolina that have that recently allowed for much higher reimbursement for telephone. But kind of for us, the proof is in the pudding. So we'll see how the claims fly through the process.
What are some of the practical concerns? Or just challenges? What type of visits? Obviously, office visits. Everyone can kind of think about that. But when CMS, as an example, and other payers opened up a pretty long list of covered services now under telehealth. What are you providing? And then I'll just add on another question, because we've gotten a lot of questions. And how do you deal with some of the, I imagine you're using e-prescribing and other technologies, but what about maybe controlled substances or agreements or other things that you would need a patient signature on the back end? So maybe talk about the type of visits, as well as when you conclude those visits, if the patient isn't there, how do you tie up some of those important matters toward the end?
Yeah, so if you want, I'll jump in there on that one. With ours, we're anything that we can push to telehealth, we're really trying to push it to telehealth. So we're really assessing to look and see, obviously all of our, well child visits, all of our annual wellness visits, kind of the healthy visits that we want to continue. All of those have been pushed to telehealth. But we're really looking at even some of our acute visits. What can we push to telehealth? And we're doing prenatal visits via telehealth. We're doing all kinds of different things via telehealth. Anything that we've been able to step back and say, do we really need to see the patient in front of us, lay hands on them to be able to conduct it? Outside of that, with what was the second part of your question? It was
just toward the end of the visit, and if it's a controlled substance that you can't e-prescribe or something like that,
right.
How do you handle those type of? We're getting questions about how you deal with things that are traditionally, something that you might have the front office deal with the patient at the end.
Yeah. So in those situations, we build in workflow to be able to help make sure that the patient receives the same kind of quality visit that they would normally. But things around e-prescribing, we made a really big push actually just before COVID. To move all of our prescribers to e-prescribing, even for controlled substances. So that transition was actually really easy for us. The only thing that we had to adjust a little bit is in our MAT services and with our medication-assisted treatment services. We've been watching the federal guidance quite closely to make sure that we stay in compliance as the rules change for that, to make sure that we can still deliver those services to patients. On the form side, things like new patient paperwork, consents, payments, everything like that, we are working with our telehealth provider, and that telehealth provider is able to actually push those to our patients. So the patient can complete all of their paperwork online, make their payment online if needed, but our MAs are also able to collect a lot of that information and push them anything that they need.
James?
I would say that one of the things that we've actually started seeing some of our doctors do, we've got a few doctors in one of our rural environments who go to nursing homes, and they are going to be using nursing home codes for virtual visits. Now, obviously, they're probably going to have one of the nurses who's got the ability to take the telephone into the patient to help make that contact and to make that communication. But in a lot of ways, when you make nursing home rounds, you typically have the floor nurse with you anyway. So this ends up being a necessary part of the visit. Some of the telehealth visits that they are allowing now I have a difficult time understanding how you would do them. They're allowing you to do hospital follow-ups via telehealth. I have a little question in my mind as to how you're going to do some of those hospital follow-up visits at that level. So we've talked about doing skilled nursing, talked about long-term care, the well child visits. One of the things our pediatricians have actually been doing it for a while, and they actually find that the well child visits, if it's not one where they're due for immunization or shot, during this period, they're reaching out, talking to the mothers, making sure the kids hitting all of the developmental milestones, making sure that they're eating well, they're growing well, and they're being comfortable saying, let's push it out we'll see you next month. I think, though, that if there are any issues or any concerns, they've been setting up times of day to see them in the office specifically. So I think that those are the ways we're doing.
How do you, if you have a practice management system in place, new codes are coming online for telehealth within the last month. You have to update the systems, the integration potentially with your EHR. How have you gone about it? We're getting a lot of questions about very practical issues like that. Just billing and updating your systems.
Day by day, we are having to look at it every day. We're adding things, we're changing things in the SIM library. We are putting front-end edits in. Shane mentioned earlier about having better scrubbing, better front-end, all of that. And we are just staying right on top of it. And it is a very labor-intensive for our RCM people. But this is potentially the lifeline that keeps a lot of the practices afloat.
So one question I thought was interesting here, and I've gotten a lot of questions about the challenges of E&M documentation and such. But one of the questions also is just about the lack of maybe experience and comfort that patients have with this mode of communication. And you talked a little bit about the provider side, they're learning, but also, are you finding that physicians and other providers are they having to spend more time with patients? Are you able to have the same kind of throughput during an average day if you could indeed schedule the number of visits that you traditionally would?
So, with our provider, we are noticing a trend that a lot of the visits are actually going quicker than what they would in real life or in live sessions. So we're actually able to fit more patients in throughout the day. Our encounter count, so far, like I said, it originally took quite a dip, about almost 50-70%, and as of Monday, at the end of last week, we were actually back up to our normal visit count per day. So we are now at what we normally see every day, and we're expecting to grow that over the next couple of weeks.
What about, I'm going to ask, so those folks who are asking these future questions, I'm going to wrap it up here in a minute. We've got a lot of really good questions about how we see this. They're going to ask you to put your prediction hat on here in a moment, but again, just going through a few more of these practical questions. Are you able to even measure success in terms of implementation of virtual care at this point? I mean, I know it's been so fast, and you guys have been standing up these telehealth systems in the last month, but is it time to measure it yet? Or, how do you go about determining success in the environment?
Yeah, so, within our organization, we are, really since the first week we did on a large scale, we have been tracking not only how many encounters that we're doing on a daily basis, but we're actually tracking, our providers utilizing the system. Are they connecting in? Are they having the video visits? Are they having to switch to telephone? What are the connection issues? And being able to track all of those things, so that way we can try and really hone the system as much as we can. Because ultimately, we want it to be successful. We want patients to be great.
James, one question that we're getting a couple examples of are, because you're using a number of systems, either formal or informal systems, and Zoom has been so dominant in terms of what we're doing on a day-to-day basis. But as we've all seen the news, there's been security concerns and others. Just from a practical standpoint, did you all invest in a Zoom license? Are you doing it more informally, or are you concerned about security issues as you've heard in the media?
We have invested in a Zoom license, and we've got Zoom licensing for a bunch of our doctors, and that was going to be our direction before they opened it up to everything. And one of the problems we found was that Zoom is rather labor intensive in terms of setting up meetings, setting up times, having to have somebody act as your intermediary. It was just not as convenient and as smooth as we would have liked it. And then immediately after we were starting to get a little bit of a handle on that, we started reading about the security and the Zoom security issues with people basically coming in and breaking into your meeting and putting things in there. So we haven't really been active in terms of jumping in with that. Additionally, I think that we need to have some sort of an AV platform. I'm not sure it needs to be integrated. I'm not sure that it needs to be a absolutely built-in part of your system to where you've got the little icon up on the top and whatever. I think that you could probably create this as an adjunctive rather than an integrated portion, as long as you're making sure the doctor documents his time and documents what they're doing with these things and which platform they're using. So we're going to be looking at this differently. The reality is a doctor who's still on paper could do video visits right now. He absolutely could get on his, right now he could get on FaceTime and call grandma, or on Skype and call grandma and make the visit, document everything they needed to in the chart, and submit the charge with that. And there wouldn't be a problem with that. And I think that that's one of the realities that we've learned, is that there are a lot of different ways to skin this cat.
I'm just going to keep, because there's so many questions and we don't have that much time, I'm going to keep asking them. There's several different iterations of the same question, and either of you feel free to jump in, but how do you overcome the obvious sort of practical implications of things like annual wellness visits, well women visits, prenatal visits, well child visits? There's a number of questions touching on each one of these.
Information, as well as vital signs, different things of that nature that we would normally collect through a physical process. We had actually one of the questions that came in was talking about devices and different things. So it's we're at a point now where we're kind of exploring how can we better that process. What avenues do we have available to us to help us better, and provide us reliable information.
One person asked for a clarification. I think I can give it. In terms of our use of the term telehealth, which we obviously are using liberally here, I think right now we're talking about audio and video, the combination. It opens up a number of doors from a billing standpoint, as well as then obviously being able to visually interact with the patient. With that, we have about 5 more minutes, and we have a lot of questions about sort of the future here. I think it's an obvious, apprehension that folks have, is that if we're going to invest a lot of money in this new modality, if we're going to spend money training staff, and we're going to train providers and get it up and running. And then James, as you mentioned, one of the fundamental things, obviously, which we can't fully predict, is that what's liberated a lot of this care is the fact that we've received a number of waivers from CMS, and other payers are doing things differently. But putting that, putting your crystal balls to work, I mean, how do you see this going forward from both a patient side as well as a business side? Is it wholly dependent on whether the payers keep reimbursing this type of care, or do you see some other opportunities to leverage this in the future?
I personally believe that, as I said, that this is going to be something that there will be too much demand. We've had 10 years, what would have taken 10 years to do the legislative regulatory relief We've had it in 2 weeks. And you've had a tremendous amount of positive impact from all of the physician groups, AMGA, MGMA, AMA, all of the specialty groups. You've also had a tremendous amount of adoption by the patient who see this. I think that there are a few things that are going to have to be there. I think that you're going to have to keep the fact that you can't have the CMS restrictions on rural. You can't have the CMS restrictions on having to go to a facility to take the call. You're going to have all of the options in terms of your coding choices out there. You're going to have a certain degree of payment parity. I think that that's part of it. One of the things they recognized is that even if you're doing a video visit, you still have to have an MA, you still have to have a billing service, you still have to have a physical location. They don't give you a break in your rent just because you are doing AB visits. So I think that at the end of the public health emergency, there will be a rapid push, I believe, to have CMS, to have regulatory relief that's persistent. And with that, I think that you'll have an immediate push down to the commercial carriers, and there will be this is my view of the world, which many people would tell you is always just a little bit rainbows and unicorns. But I think that it's going to have to be. I think there will be too much push. My daughter saw a pediatric allergist virtually yesterday for her 10-month-old, and was able to show pictures of her urticarial eruption, and was able to have the doctor. And when she got the bill for $200, my daughter paid that. Said, I didn't have to go out. I didn't have to do anything. The pharmacy's delivering my medicine tomorrow. She's thrilled to death, and didn't bat an eye. And I think that that's going to be, that there are a lot of people out there who are going to be happy with that, and they're going to be thrilled to death to not have to go into the doctor. I think that urgent cares are going to find that this is a niche for them to explore. Even though they're not the primary care providers, I think that that's going to be a niche they're going to look at. So I personally think that this is where things are headed.
Shane?
Yeah, so our hope, within this, is that a lot of the changes policy-wise that are going on right now, both at the state and federal level, will stick. We really want to see a lot of the opportunities that are being held right now, be available for patients for the long term. There's nothing worse than being able to offer something and then having to take it back, because of policy change or whatnot. I'm talking with a lot of our leaders here at the state level in North Carolina, as well as some of our federal leaders. There is a lot of discussion that's going on right now. There's a lot of policy being introduced to help change some of the things that we're going forward with. I know here in North Carolina, we've seen some of our clinical policies change. I know that they're hopefully getting ready to introduce a telehealth parity bill with legislation. So we're excited that the momentum that this has brought in this unfortunate time for telehealth. I think I think many of the things will stay the same. With I say same, I mean Leah talking right now. With what we're seeing, while I think some things will go back. Will we see things like FaceTime and the unsecure platforms? I anticipate. We'll get a notification that says, at the end of next week, you need to stop using it. While some of the things such as payment for certain services, I anticipate some of that to stick around. But I know a lot of payers right now are doing a lot of research to see what is the right answer. So, let's wait and see.
Well, I just want to thank James and Shane. We really appreciate your time today. And the audience, we had, it looks like over 100 questions. So we did our best to try to get through as many as possible and bundle them up. But clearly there's a lot of interest in this. And, I know that from AMGA and MGMA, we're tirelessly advocating on behalf of our members to try to help them get through this crisis. And, telehealth, obviously, is one of those ways that we can do it together. So thank you both for sharing your experience today. And thank you, everybody, for joining us for this webinar.
Thank you both, and Andres as well, for your time and experience sharing today. Please, everyone, mark your calendars for another collaborative call that MGMA and AMGA will be doing next week on cash flow. We will have promotional details coming out shortly. And this concludes today's presentation. Thank you.